Welcome back to Long Covid Doctor, an educational series for sufferers of Long Covid. I'm Dr. Tim Robinson, formerly a GP for 30 years, now GP lead for 3 NHS Long Covid clinics, and a GP clinical lead in Long Covid across the southwest of England. This episode is on breathlessness and Long Covid. In part 1, I talk about the symptoms and diagnosis and investigations. And in part 2, I will talk about the treatments, management and outcomes. References, links and resources are in the show notes below. Any advice, diagnoses, treatments that I mention should only be considered after discussion with your own GP or qualified health professional. And so here we go, breathlessness and Long Covid. Breathlessness is a common symptom of Long Covid. As I say, it's sort of one of the big three, along with fatigue and brain fog. Breathlessness, in my experience, in the Long Covid services that I work in, is very common and it has a great impact on many of my patients. So, first of all, the symptoms and associated symptoms. Breathlessness, as is defined, is being short of breath, the feeling of not being able to catch your breath, to feel your lungs, to the feeling of suffocation that some patients describe. Breathlessness may be experienced only upon exertion, such as when you're walking upstairs, or it may be with simple activities of daily living, say washing, showering, dressing, or even eating. Or perhaps even just at rest. Patients, describe the feeling of being breathless at rest, which they never had before they had COVID. There may be associated symptoms with the breathlessness, such as cough, chest secretions, sputum, throat discomfort, hoarse voice, swallowing troubles. There may be associated chest discomfort, chest tightness, like a sort of the rib cage is being constricted and sort of clamped and with a band around the chest. The so-called COVID grip. Or there may be actual chest discomfort or pain across the front of the chest or just on one side. Breathlessness is often associated with sort of fear and panic, and this is understandable, of course. It's an understandable reaction. If you can't get your breath, it makes you feel panicky. So then, what do we do about it? Okay, so, one step at a time. First of all, we've got to sort of figure out why someone is breathless and actually to sort of get a diagnosis. So the way we do this is, just good old-fashioned medicine. We talk to the patient, get the history, the narrative, and then examine the patient. So general history. First of all, we're looking, for sort of the features of the breathlessness. But like I said, it's in order to get a diagnosis. Specifically looking for possible differential diagnoses. What do we mean by that? Differential diagnosis? Basically, other causes of breathlessness other than COVID. So what are those differential diagnoses, those other causes of breathlessness? Well, it might be because the patient has an existing underlying chest disease or illness, such as asthma or COPD, chronic obstructive pulmonary disease. Or they may have breathlessness because of a medication, such as an ACE inhibitor drug. The patient may be breathless because of anemia, for example, iron deficiency anemia in particular. The patient may be breathless because they've been unfortunate and had a severe case of COVID, and they ended up on a ventilator on the ITU. Equally, if they've had severe breathlessness, a severe attack of COVID, it may have left them with scarring of the lung and interstitial fibrosis. They may have a pulmonary embolism, a blockage, a blood clot on the lung. They may have pneumonia, lobar pneumonia, low-grade lobar pneumonia. They may have reflux of acid from the stomach up into the upper airways, causing cough and breathlessness. They may have sleep apnea. There's the condition when there are absences of breathing, interruptions of breathing during your sleep. And finally, they may have a condition called breathing pattern disorder. I'll talk about that a bit later on. So, as I say, history really important to actually find out about other conditions which they may have coincidentally or pre-COVID, which may in themselves produce breathlessness. But history is equally as important to find out all the specific features of their breathlessness. Is it only at rest, or is it only on exertion, or is it posture related? Is it the same day and night? Are there associated symptoms such as cough or pain or the phlegm I referred to earlier? And in which case, what's it like? What's the sputum like? And is there any blood in it, for example? So having come to the end of the history taking and having a good idea about the various characteristics and specifics on how the patient is experiencing their breathlessness, it's next on to examination, routine general examination, with an emphasis on the respiratory system and the cardiological systems. So first of all, we look at the patient. The patient may look anxious. As I said, being breathless makes you feel a bit worried, anxious, concerned. Equally, we look for any blueness and what we call cyanosis, and that could be central or peripheral cyanosis. We want to get a mark of how breathless someone is by recording their respiratory rate, how many breaths per minute. Again, still on observation, are they breathing normally, or are they breathing through what we call pursed lips, where they've got their lips fixed and they're using their lips to control their breathing. Is the breathing shallow, or does the breathing, appear deep and talking about the rate, is it rapid or is it slow and gentle breathing? And then the doctor would want to have a listen to the chest with the stethoscope and to listen for any wheeziness, any crackling that would suggest heart failure, any rubbing that might suggest a blood clot on the lung. Cardiovascularly, the doctor will want to measure the pulse and the blood pressure, look for signs of heart failure, ankle swelling, or raised jugular venous pulse. And then to quantify the respiratory system, I think we would want to see what the oxygen saturation is. So you can use a pulse oximeter on the finger, preferably not a smartwatch. The readings are notoriously misleading. I've had many patients report a very low blood oxygen level with their smartwatch, but when it's reproduced using a proper pulse oximeter, it's normal. Resting oxygen saturation should be more than 96%, and if it's not, then that's perhaps an indication that referral for a respiratory opinion might be indicated. Whilst you've got your pulse oximeter on your finger, it's a handy way of assessing what we call desaturation with exertion, to see just how you cope with exerting yourself, and that is sitting to standing on a repeated basis over 1 minute, the 1 minute sit to stand test. And if your oxygen level drops by more than 3%, or certainly less than 96%, more than 96% or less than 96% after doing that test, you really ought to be asking the opinion of the respiratory specialists. There are other things that the GP might consider to do in the GP surgery, so peak flow and spirometry, specifically looking for sort of the breathing efficiency, the lung capacity and elasticity of the lungs. So all good markers and routine tests in the surgery to investigate for breathlessness. So that's history and examination out of the way, like I said, in order to arrive at a diagnosis. But the other thing we've got to be on the lookout for always are red flags. So those signs and symptoms that suggest something more sinister. So red flags that we'd be sort of on the lookout for in a patient who is breathless would be sort of an unexplained associated cough that is new and it's been there for more than 3 weeks. That is a red flag. Unexplained weight loss, blood in the sputum, especially if the patient is a current or previous smoker. Any massive or progressive weakness. All of these, we're all on the lookout for as red flags, because they could well be indicators of something more sinister, like I said, such as a lung cancer. So any of those red flags should be actioned, and usually it results in a referral to the hospital doctors, to specialists. Other red flags that would make you suspect, say, a blood clot on the lung, or such as, i.e. pulmonary embolism, would be a sort of sharp, one-sided chest pain that's sudden onset, associated with recent bed rest or swollen calf. Those are red flags for pulmonary embolism. So, referral to the specialist in the hospital would be indicated. So that's history, examination and red flags. What happens thereafter? Well, again, in general practice, your GP would want to be doing the baseline blood tests. And these are the baseline blood tests that are recommended by NICE guidelines for long COVID. And, you'd be wanting to do a full blood count. You'd be wanting to do a liver and kidney function tests. You'd be wanting to do send blood for CRP and ferritin, looking for inflammation. Again, the routine bloods that are on the NICE guidelines for long COVID patients. And they also include thyroid function tests and HbA1c for looking for diabetes, BNP for looking for heart failure. Another blood test that is frequently requested by long COVID clinics is the D-dimer, which is a marker of blood clot. But beware, there are often false positives. So your D-dimer can be positive, but not only for blood clot, but after infection or lung injury or persisting inflammation anywhere else in the body, can all lead to increased D-dimer. So, or because your D-dimer is elevated, it doesn't necessarily mean you've got a blood clot. Likewise, you can have false negatives. So I've seen patients with with pulmonary embolism and also indeed microclots, much talked about, quite controversial, with a negative D-dimer. Other tests need to be done if you're really concerned that there's a high likelihood of either a pulmonary embolism or a microclots. And then, of course, the other investigation, which is obvious really, and in anyone who's breathless, is a chest X-ray. Acute COVID shows this sort of ground glass opacification, but it's not necessarily present in patients who have had mild non-hospitalization COVID. So again, but I think it should be indicated by anyone with breathlessness or certainly other associated symptoms such as cough. We mustn't be sort of COVID blind, and or because someone has breathlessness and COVID, we mustn't sort of be complacent and think, okay, because they've got breathlessness and they've had COVID, it must be all due to the COVID. Other conditions may be present. If the patient is then referred to hospital, then they may have more specialised tests, such as a high-resolution CT scan, a VQ scan, ventilation perfusion scan, a CTPA, so it's a CT scan with pulmonary angiography, looking for blood clots. You may have heard of the xenon gas MRI scan, which shows hidden lung damage even in the presence of a normal CT scan. But this is really just research purpose only. They cost £1,000 a go, and so, like I said, it's only been used for research purposes, and really it only comes up positive for those patients who have really had a really severe bout of acute COVID, so not the majority of our long COVID patients. The other tests that is often done in the hospital setting are respiratory function tests, the transfer factor, DLCO they call it, diffusing capacity for carbon monoxide. That sort of measures the passage of oxygen from the air sacs, the alveoli, into the blood. This is reduced in inflammatory conditions and also blood clots. So that is the whole sort of plethora of investigations that can be done in any patient who has breathlessness due to long COVID. But obviously, it's a case of tailoring the case to the investigations that need to be performed. Not all patients will have all those exhausting list of investigations that I've listed there. So having excluded the differential diagnoses and the red flags, we're left with the diagnosis of breathlessness due to long COVID. Like I said, we don't want to be COVID blind. I just, as I sort of explained, or because you've got breathlessness and you've had COVID, it's all due to the COVID. No, there may be other differential diagnoses, and having excluded those, from now on we can make the diagnosis of breathlessness due to long COVID. So what are the causes for breathlessness due to long COVID? I think it's important to know the causes because it helps the patient understand and hence accept the problem. It also reminds the patient of the complexity of long COVID and that all the things that can go wrong with long COVID, and hence the reason why fixing it is never going to be possible by doing just one thing. And so what are the possible causes? What we call the pathophysiology for breathlessness in long COVID. Well, hold on, there are lots. So the COVID, the coronavirus, the SARS-CoV-2 infection can cause all sorts of damage to the lung structure. So that can lead to sort of scar tissue, interstitial pulmonary fibrosis, scar tissue within the lungs themselves. The COVID can lead to damage of the lining of the air sacs, the alveoli, and so there's a barrier for oxygen to transfer across the alveolar wall and into the alveolar capillary blood vessels. So oxygen is not passing across those tissues into the bloodstream. COVID can cause excessive inflammation of the blood vessels, the alveolar capillary blood vessels. So inflammation of the blood vessels themselves. So endothelialitis. So there's a link in the resources in the show notes below, which demonstrates that very, very well in a study. Again, it's blocking the oxygen passing from the air sacs into the blood vessels. The blood is therefore not being oxygenated. And then there's the whole story of microclots, the mini clots that can occur anywhere in the body. Very difficult to detect. Again, if you've got blood clots in the blood vessels, the network of blood vessels surrounding the air sacs, oxygen is not going to get into those blood vessels, and blood is not passing through those blood vessels, so oxygen is not going to get carried away from the lungs to the rest of the body. Again, there's another link in the show notes below that talks about this. Then there's COVID infection that's causing lining inflammation of the lining of the lungs. I sort of hinted at this earlier. So inflammation of the lining, that's called pleuritis. That causes sort of discomfort with breathing. The patients call this the COVID grip. And there's reduced air entry into the lungs if you can't take a deep breath, because you've got COVID grip of your lungs. You can't, basically take a full deep breath, and then that's going to cause a sort of a subjective feeling of breathlessness. COVID can cause a dysfunction of the immune system, so autoantibodies have been found, so antibodies against your own normal cells have been found against that sort of act against the cells lining the air sacs. And then there's also dysfunction of the carotid bodies. These are the sense organs in the carotid artery. Oxygen concentration in the body that sense the oxygen concentration in the body and drive respiration. If those cells are damaged, that then causes dysfunction of the normal breathing pattern. So, and there's more, the virus can actually affect the heart muscle, causing myocarditis, which then can cause heart failure, which then presents as breathlessness. But you can also get breathlessness due to general body deconditioning in any severe illness. And finally, you can get breathlessness due to anxiety and breathing pattern disorder, in which there's sort of shallow, rapid breathing due to worries, anxiety. Like I said, feeling breathless can cause sort of worry, but also worries can cause breathlessness, because you tend to breathe fast, breathe shallowly, not breathe efficiently. So, as you can tell, it's very complicated. One person may have one of these processes going on, leading to the breathlessness, or they may have a number of these processes going on, or they may have all of these processes going on. All of them can contribute to breathlessness. So it's little wonder that long COVID causes so many symptoms in so many systems throughout the body. It is complex. It is, as I said before, it is the perfect storm. So that's the first part of my talk on breathlessness and long COVID. It concludes the first part. The symptoms, the diagnoses, the investigations, and the pathology behind it. In the second part, I will talk about the treatments, the management, and the outcomes. So I hope you've found that helpful. As I've mentioned at the start, any advice, diagnoses, treatments that I mention should only be considered after discussion with your own GP and qualified health professional. So in the meantime, I wish you well, and I wish you well with your long COVID recovery.